Hello, everyone, and welcome back to It All Starts Here, a podcast focusing on the communication and education of topics in reproductive science and women's health. I'm your host, Olivia Moir, and we are back here today at the Institute for Women's Health here at UCL. And today we're going to be talking about maternal mental health, right around and sort of following childbirth. You may have heard of this under the tagline of baby blues, but we're going to be diving a little deeper into it with none other than the lovely Dr. Chiara Petrosellini. Chiara is an academic obstetrician and gynecologist doctor doing her research here at UCL, where she's completing a PhD focused on maternal mental health, which we will dive in deeper shortly. I'm so excited to get into this with you today, Chiara, and really just learn more about this time in mothers' lives. But first, let's hear from you about how you got into this and where it all started for you. And just so everyone listening is aware, this episode will be discussing sensitive topics like mental health and suicide, so just a message to take care while listening. Now let's get started. Chiara, let's hear from you. How did you get into this?
So thank you for having me. First of all, I'm very grateful to be here. So I'm Italian. I grew up in Italy, and I first went to UCL when I was 18. So I moved to the UK to study human genetics. And in that time, I did a bit of research in psychiatric genetics, so the genetic aspects of mental health. And I became super fascinated with mental health, mental illness, and I really wanted to dive deeper. And I basically went to medical school just to be a psychiatrist. I only had that one objective. I didn't just want to be a doctor. I wanted to be a psychiatrist. And then basically I accidentally fell in love with obstetrics is what happened. I realized that there were so many aspects of looking after women that fitted my personality and that definitely was the right career choice for me. But also, somewhat to my surprise, mental health and mental illness was an enormous part of obstetrics and gynecology, a very neglected part, as I'm sure we'll go on to talk about. But I realized that this was the perfect way for me to combine lots of interests, and that doing obstetrics, looking after women, definitely didn't mean that I wouldn't be able to explore my interest in mental health because there's an enormous need for it. So that's kind of how it all came together.
So cool. I feel like that is such a common theme of how you start school down one path and then, what's not to love about obstetrics? I think it really pulls you in.
Yeah.
So I guess getting into our topic today, which the very technical term being perinatal mental health. I wonder if you could just sort of introduce that for us and describe what does that mean and just a broad overview, I guess, of that period of
Yeah, of
motherhood.
course. So basically, peri means around and natal means birth. So basically, perinatal mental health refers to the mental health of a woman or birthing person over the course of pregnancy and throughout the first year of after childbirth. And as a field, it's kind of developed for people to have expertise in mental illness that existed before pregnancy. So you might have heard of, say, like depression or even schizophrenia. So women who have pre-existing illnesses who then get pregnant and who will have special needs within that time. But also illnesses that are unique and that emerge for the first time in the perinatal period. So things like postpartum depression or postpartum psychosis that we'll go on to talk about. And the reason it is its own thing is because perinatal mental illness has really distinctive features and risks. So you can't just extrapolate from what you know about mental health in general, because there's something extremely unique about this time. I think it's important to set the scene with some stats. I feel like that's always gives you a good idea of the context. So we know that over 1 in 5, probably closer to 1 in 4, women will experience a perinatal mental health problem during pregnancy or in the first postnatal year. But we also know that in about 70% of cases, women will hide or underplay their illness. So not only are problems common, but they're also associated with quite a significant level of stigma, which means that women don't feel able to talk about them openly. So they're common and people are suffering in silence, in part because of the stigma, in part because I think women don't feel that clinicians are equipped to really understand. And to put that into perspective, I'm saying 1 in 4 women will experience a perinatal mental health problem. Other things that we talk about commonly in pregnancy, say gestational diabetes, that's 1 woman in 20. So this problem is common, and they're much more common than some of the things that we kind of like to talk about a lot in obstetrics. And unfortunately, in this country, suicide is the leading cause of death within a year of having a baby, which may come as a surprise to some people listening. But it's true, and it's been the case for a really long time. I think we've become really good at dealing with some things like infection or hemorrhage and things like that in this country around childbirth. But we're really not very good at mental health, in my
Mm,
opinion. Unfortunately, women in this period are really, really vulnerable, and they are at higher risk of death from suicide, but also from things like substance misuse or from misattribution of physical symptoms to psychiatric illness. And what I mean by that is, someone who has a pre-existing mental illness, essentially any complaint that they come with, they get kind of, just semi-ignored, and it's just assumed that it's all part of their mental illness. And that's how serious things get missed. Um, and, a striking statistic as well is that if you look at all of the women who die in this country, about 50% of them are known to have a pre-existing mental health problem, irrespective of why they die. So this cohort of people is very, very, very vulnerable. And that's what sometimes gets ignored. And that's also why I'm passionate about it. But it's not just about mortality. Mental health can have an enormous impact on the mother infant bond and on the development of the child, particularly when there's delay in recognition of the problem. And
mm,
that's more on a kind of societal level. The last time this was costed, the perinatal mental health problems cost the NHS and social care services over £8 billion for each 1 year cohort of births. And that was costed like over 10 years ago. So the impact truly is enormous.
So how does this, like, as you said, a lot of it, not a lot of it, but a good amount of women will, ignore or kind of maybe have self-doubt about the symptoms that they're experiencing. I mean, not to mention that, just after delivering a baby, I'm sure you're just insanely busy all the time. Like I've seen that with mothers and you barely have time, I think, to think about yourself in that period. And if you are going through something that seems like a mental struggle, I agree there's a lot of stigma around that where if you're not basically physically, you know, unable to complete your tasks as a mother, I think it's hard to bring yourself to take that time out of the day to go in to see a doctor. But I think if someone is going in to see a doctor, how is that evaluated? Do we have a sort of standardized test for specifically this period of time for women?
So that's a really good question. So there are some what we call screening tools. So let's say kind of brief questionnaires that help us identify who is more likely to have a problem. They're not really used universally. So that they're used, some very, very basic ones are used in pregnancy.
Mm-hmm.
And essentially they are very good at picking up someone with a problem, but they're not very specific. So they will pick up a lot of women who just have normal kind of adjustment problems. And this is part of the difficulty because really the skill is in unpicking what's normal from what's not normal.
Mm,
So arguably becoming a mother is the biggest biological, psychological, social change that a woman will ever go through. So it would be weird if there was no change in the way
mm-hmm.
that they feel about themselves, about the world. So a level of challenge and difficulty is completely normal. But then on the other end of the spectrum, there is life-threatening illness, um, sometimes that can present as an acute emergency and can present imminent danger for the woman herself and for others. And so the skill as a clinician is to really try and unpick what's normal and what's not normal. And I guess
Mm,
in answer to your question, it's not easy. And there's challenges in part because, appointment times and things in the NHS are limited. But I like to think that there is growing expertise in this and that people are developing those skills where they can really listen and not kind of brush everything under the carpet and say, oh, just get on with it. It's just part of motherhood.
yeah, absolutely. And I think it's just, I mean, I'm watching a show at the moment on the BBC called Call of Midwife. I'm sure you're so familiar with. I've never watched before, but it's interesting to see kind of like how it all started, I think, in this field, and the role that midwives played in advocating for mothers and saying, obviously it's a TV show, but definitely it's grown so much, and it's such an important role that doctors and midwives and nurses play in this period for mothers. Going back to the concept of this and where, it all starts, really. What leads to this being such a vulnerable period for women, as you said? I mean, you kind of alluded to the biopsychosocial model, but could we kind of unpick that and sort of understand more about what that really is?
Yeah, of course. So the biopsychosocial model is a model that's been used a lot in psychiatry in general to explain why mental illnesses might happen, but also why they are perpetuated. So what keeps them going, but also more importantly, how to treat them. So in
Mm,
most people, a mental health problem will arise as a combination of biological things. So, for example, whether you have a genetic predisposition to something, or if you are particularly susceptible to hormone change or sleep, as I'm sure we're going to talk about a little bit more. Um, Psychological aspects will be more to do with your perception of change and your ability to cope, your own kind of coping strategies and attitudes, I suppose.
mhm,
And then social things are, anything to do with social support. So who you have around you, if there is, sudden bereavement or change in housing, and and that's just to name a few examples. So I suppose for each individual woman, those three kind of uh, fields will play different roles, and it will be a unique combination for each person. Often there's a combination of all three. Um, and it's so important that care for for these problems is individualized. So the best way to understand a human being is to try and understand what bits of each of those spheres is coming into play. I just wanted to pick up on you mentioned the word vulnerability.
mm,
And I think it's really important to recognize that this is an extremely vulnerable period of time for any woman, irrespective of whether or not they've had a mental health problem before.
yeah,
And there was a pivotal study that was done in the 80s where they basically followed up nearly 500,000 women for a period of at least 12 years. And basically they recognized for the first time that the risk of being admitted to a psychiatric hospital, the relative risk is extremely high in that first month after childbirth. And particularly looking at first time mothers, they are 35 times more likely to be admitted to a psychiatric hospital in the first 30 days after childbirth than at any other point in their entire life. And this concept, let's say, has been replicated in lots of different cohorts all over the world since then. And essentially, the basic principle applies both to women with and without pre-existing mental health problems. And so I think it really is important to recognize, both for women themselves and for clinicians who might be listening to this, that irrespective of what may have happened to someone before they ever got pregnant,
mm,
irrespective of whether or not they have a history of mental health problems, we know that this is the most vulnerable time in a woman's life with regards to her mental health. And what I'd say to some of my colleagues that aren't particularly interested in mental health is, regardless of whether or not you like it, if you are going to do obstetrics, you are looking after women at the single most vulnerable time in their entire life
yeah.
with regards to their mental health. So it's about keeping your eyes and ears open to the possibility that this could happen.
Yeah. And I think we'll get into it later when we're talking about some different sort of myths and misconceptions to bust. But I just can't help but say at the moment, like, how you describe this and how common it is, and sort of the importance in being a doctor that is able to recognize that and the prevalence. And I think as well, what's really interesting, is that the public perception is a lot around biological factors that go into this, you know, but there are so many factors, as you said, even just within those three kind of headers under the biopsychosocial model. And it's just so interesting to unpick it and understand it more. So I guess going more into it, what these conditions are, as I said at the beginning of the episode, I think the one you hear the most commonly is baby blues. I mean, definitely I've heard of postpartum depression, but I know that there is more to the story than just those two. So could you kind of run us through the conditions that we need to be aware of?
Yeah. So, I mean, as I mentioned before, perinatal mental health and perinatal mental illness, it's a spectrum from normality to severe illness. And it's important to bear that in mind because there's 50 shades of grey, let's say, within that spectrum, and it doesn't always fit into neat little boxes. Um, but I suppose in terms of some key highlights that people should be aware of, you mentioned earlier the term baby blues. So that's considered a non-disorder in the sense that we know that 60 to 80% of women will experience baby blues. So it is considered essentially the norm to an extent. And essentially what that means is that around day 3 to 5 postpartum, usually when the milk comes in, um, sometimes, in relation to a sprinkle of sleep deprivation, there will be a change in mood that is transient. Women may feel irritable, tearful, overwhelmed, and it's very, very common and it's
Hmm.
not considered a disorder. But the really important thing there is that it will get better very quickly and it will respond to reassurance. So what that means is if you are able to have support and have a nice chat uh, with your family, your friends, get a good night's sleep, get some rest, it will get better very quickly. And it doesn't compromise your ability to function and to look after your baby. And that's why it's not an illness. But by contrast, perinatal depression is an illness. And the reason for that is because, so firstly, by definition, symptoms need to have lasted at least 2 weeks. And most of the time, they're grumbling symptoms that have gone on for a really long time. But importantly, they do compromise your ability to function as a person. And that's the difference. And it can affect so many different spheres of your life. So it's not just that you will be low in mood.
Yeah.
They're often what we call somatic changes. So significant changes in your ability to eat, in your ability to sleep, and to care for yourself and to care for your baby. It's pervasive. So it affects every domain of your life. And it doesn't respond to reassurance. It doesn't respond to a bit of a hug and a good night's sleep. And that's the biggest problem, that when women are really struggling, often they get dismissed with like, it's a bit of the baby blues, just have a good night's sleep. And actually it doesn't make any sense because, they're 5 months postpartum and they've not slept for 2 months and have been crying every day. That's not baby blues, you know?
Yeah.
And that's a really, really important distinction to make.
Yeah. So I'm guessing that that sort of distinction is where the lines get blurred, between baby blues and postpartum depression, where something continues on for longer than it really is meant to. But I'm guessing that the threshold to get to that full kind of postpartum depression diagnosis is too high, in practice, when in reality, it's probably much lower than is treated for.
Yeah, absolutely. I think it's extremely underdiagnosed. In the States, they say that it's the single most underdiagnosed condition of pregnancy. And it's exactly for the reasons that you've just said.
Yeah.
Um, so another important condition to be aware of is postpartum OCD, so obsessive compulsive disorder, because it's really frequent and underdiagnosed. And this is possibly one of the most stigmatized ones that women don't want to talk about because they feel incredibly guilty about the thought processes that they're having. And basically, OCD is a condition where you have obsessions, so um, intrusive thoughts that you can't get rid of, compulsion, so the need to perform certain acts, usually to relieve the anxiety caused by those thoughts, or you have both of those things in a cycle. And it's not just, the stereotypical thing of people washing their hands 10 times a day or whatever it is. It's much more complex and common than that. And in the perinatal period, very often there will be intrusive thoughts related to the baby. For example, things like, what if I drop my baby? What if I let the stroller go and then it ends in the lake, for example? Or what if I hurt my baby? Or even darker thoughts than that. The problem is that because women are having these thoughts, they assume they're a horrible mother. It fuels their depression and it fuels their inability to speak about it. And also clinicians think that if someone is saying to you that they have thoughts of harming their baby, then their instinct is to say, oh my God, she's psychotic, she's dangerous, lock her up. But in reality, it's completely different. And the key here is to figure out if those thoughts are what we call egosyntonic or egodystonic. So you need to ask the person how they feel about that thought, because a person with OCD that has a thought of harming their baby will feel awful about that thought. They will feel like a horrible human being and will have no intention of acting on it because it is completely out of line with their sense of self and what they would do. But by contrast, psychosis is different. And a thought of harming themselves, their baby, or whatever it is, will come from a place of it making sense to them with regards to what their reality is. And so they don't feel guilty or scared by that thought. That thought is in line with their mental state. And
Right.
it's a really important distinction to make. So I think what I think is important to let women know is that having intrusive thoughts like that in the perinatal period is very, very common. And also OCD will target anything that scares and matters to you. So often, the more you care about something, the less likely you are to want to hurt something, the more likely you are to have those intrusive thoughts. And it doesn't mean that you're
Right.
a horrible or dangerous parent. And once again, it is a very treatable condition. So feel free to speak out because it doesn't make you a horrible human being. Thoughts are just thoughts and they can be dealt with.
That's really interesting. So, diving more into the psychological aspect of the biopsychosocial model, one thing that we've talked about, and I think you've already mentioned briefly, was birth trauma. What and how does that kind of impact perinatal mental health, and how is that related?
Yeah, so I think in terms of psychological factors that feed into perinatal mental health and mental illness, a big part of the problem is thinking a little bit about how we process change, because obviously, um, as we mentioned, motherhood is a time of enormous change, and so your internal coping mechanisms for processing change will somewhat dictate what ends up happening. And birth trauma is kind of part of this. And it's unfortunately very, very common and it's increasingly recognized. But it's important to think about trauma more broadly and what that word means. So in general, when we say trauma, we're referring to actual or perceived threat of death or serious injury. So someone will feel traumatized if at some point there was a real or perceived feeling of dying or serious injury. And in this context, it will apply to uh, a woman, or she felt that about her baby. So she seriously thought that herself or her baby could die or could be seriously injured. And whilst, if you look at the stats, it'll be under 10%, so 5 to 9% of women meet criteria for childbirth associated PTSD. Um, Actually, this isn't something that we routinely screen for, so the numbers could be higher. But if you go out and just ask women in a binary fashion, was your birth experience traumatic? Yes, no. The numbers are much, much higher. So the literature says
Mm,
about 44%, and my data from my research is not dissimilar. So almost kind of 1 in 2 will say yes. Um, but so importantly, um, it's not about what, let's say, objectively goes wrong in that birth. It's not about what we as obstetricians might say is an emergency or a complication. Because I've certainly had lots of women who have had lots and lots of very complex emergencies and complications over the course of their childbirth experience that then process this fine. Whereas there are some people who will have what we would deem to be a completely straightforward birth experience who feel traumatized. And
right.
ultimately, although there is so much data and research in this field, I think it can be drilled down to some very basic concepts. So this is basically a subjective view of the delivery as a negative experience, and it's irrespective of the peripartum kind of complications. And to me, it all comes down to two things. It's about control, first of all. So if there is a perceived lack or loss of control, that leads to trauma. That makes people feel traumatized. And also suboptimal communication and support. So it's those two things. So if people feel unsafe and if people feel like they've lost control, that's when trauma happens. And there are
Mm,
so many studies showing that actually what makes a difference isn't the actual complication that happens. It's about how we communicate around it
mm,
and whether or not we do things to empower women to feel safe around that experience. Um, and so I think what I'd want to say to women is, first of all, that unfortunately it is common to feel traumatized by your birth experience. And you shouldn't accept the one-liner of, oh, but aren't you glad it all went well in the end? Because that's not what defines trauma by definition. And you
yeah,
are entitled to your trauma, even if everything went well on paper.
yeah,
Um, and similarly, as clinicians, don't assume that you know whether someone in front of you will be traumatized or not, because it's not about what went wrong or what could have gone wrong. It's about
yeah.
the subjective experience and whether or not there was loss of control and whether a woman felt unsafe in that process.
I love how you broke that down. I think it's probably something a lot of people, including myself, haven't heard in that way before, the concept of how trauma develops. And I think it's important, especially in this period of childbirth where you just feel like you absolutely have no control. Um, so it's really interesting to learn about that, and how that can play into it. And then going further into some other conditions to be aware of. So I know you mentioned before to me postpartum psychosis. What does that look like?
So postpartum psychosis is the focus of my research. And I think what I want to say about it is that it's a medical emergency, but also that it is treatable and people get better very quickly and very effectively. Um, but it is also extremely underdiagnosed. So it's a severe condition um, that happens in up to 1 in 500 people who give birth.
Mm,
And it can present in lots of different ways, but essentially the key feature is as a bit of loss of touch with reality, hence the term psychosis. It's serious because almost always the symptoms start very suddenly and women get worse very, very quickly. So it can present with what we typically call psychotic symptoms. So that would mean delusions, hallucinations. So that either hearing things or seeing things that aren't there or believing things that cannot be true. Um, but what's often a misconception about this condition is that although these psychotic symptoms are very prevalent, they are not the defining feature. The defining feature is a very big mood component. So you can have mania, so a state of persistently elevated or irritable mood, where you're not sleeping, not eating, kind of functioning at a million miles an hour,
yeah.
or profound depression as well. So it's not that it sits in a completely separate box to perinatal depression, because you can also have profound depression within this. But importantly, you can also have disturbances in kind of your cognitive function. So women are often very confused, um, and they will come in and out of this state of perplexity where things don't really make sense. And for the medics listening to this, it looks a lot like delirium, actually, like what you might see in the elderly, for example. And so one of the problems with this condition is that it presents in lots of different ways. It changes very quickly, and so it's hard to spot.
Right.
But essentially, because of this gradual loss of touch with reality and these fixed false beliefs that are associated often with the baby, it's a medical emergency because it is associated with a significant risk of suicide and or infanticide.
Mm,
And so it needs to be treated as a medical emergency because things escalate so quickly.
of course.
Um, I think it's important to say that although there are some recognized risk factors for it, in about half of cases, there is no history of pre-existing mental illness. And so once again, it's about kind of looking out for it and realizing that
Yeah.
it's more common than you might think, because it's often branded as rare. But I really don't like that term, because rare, first of all, it's not rare. By definition, it's uncommon. But also the term rare kind of has this implication that it's something that you don't really need to know about. And a comparison I quite like is that it's just as common as Down syndrome. And screening for Down syndrome and pregnancy is something that we all talk about all the time, and extensively counsel women on the various screening, approaches. But no one talks about postpartum psychosis. So
Mm,
again, that goes back to stigma. Why is that?
right. Yeah, you definitely hear about Down syndrome, quite a bit. So it's a really good comparison to make. I think that's really interesting, as well, about how it's sort of branded in terms of it being rare versus uncommon, and important, obviously, to make that distinction and communicate that differently. Um, I think that was one of our kind of key misconceptions that we wanted to bust, but I know the other one was around the lack of sleep, which I think mothers listening will just love to hear because, it is definitely branded like it's just part of it. That's just what you see, lack of sleep is normal.
Yeah, of course. I mean, so I'm particularly interested in sleep, as that's the focus of my PhD. Um, and it's a very fascinating thing to study, actually. It's something that we all do, but not very many of us know anything about it. And it's a whirlwind, I'll tell you. But I think the first thing to say is that sleep is not just the absence of wakefulness. It's a very active, tightly regulated metabolic process that is absolutely fundamental for your health. And it's got lots of different biological functions. And just to name a few, it's when you sleep is when your cardiovascular system shifts from a kind of sympathetic nervous system state, so your fight or flight, to your parasympathetic nervous system, so kind of rest and digest, calm down. And so it's fundamental for your cardiovascular health. And it's also when your glymphatic system works. So that's a network of capillaries in the brain that clears waste. So that's literally when the brain is getting rid of its waste products. It's when your immune system gets regulated. When there is insufficient sleep, there is an association with kind of immune dysfunction, but also DNA damage and therefore cancer risk. But it's also when your neural connections get strengthened. So that's kind of how memory consolidation and learning happens.
Mm,
And so these are all fundamental processes. Um, and in the perinatal period, basically, for a combination of reasons, sleep gets worse. So even within pregnancy, we know that things like being breathless or needing to go to the toilet or being in pain mean that your sleep will be really kind of disrupted. Um, but we also know that the hormones of pregnancy, so estrogen and progesterone, will affect sleep architecture. So that's kind of the structure of your sleep. So the hormones will interfere with your ability to maintain both non-REM and REM sleep. And also disorders of sleep are more common in pregnancy. So whether that's insomnia or restless leg syndrome, sleep apnea. And so as a combination of all of these reasons, as pregnancy progresses, sleep quality worsens. And what people often fail to recognize is that sleep is awful even before the baby's in the picture. And so
mm,
women already get to that point when they're in a sleep deprived or sleep deficient state. Um, and then there's the bit that we all know about, which is that basically postnatally, there's a significant reduction in how long you get to sleep for. But there's other parameters that change as well. So, for example, your sleep efficiency gets worse. So that's basically your ability to capitalize the sleep that's available to you. So what proportion of time in bed do you actually spend asleep? There's so much about sleep that changes in this time. But importantly, we know that it correlates really strongly with mental health problems.
mm,
So insomnia in particular has the most evidence. So insomnia is the inability to initiate or maintain sleep, but despite the opportunity to sleep. So a baby waking you up all night, that's not insomnia. But if you're lying in bed, wide-eyed, unable to sleep, even when the baby sleeps, that's insomnia, and that's different. And so we know that insomnia correlates really robustly with depression, both in pregnancy and postpartum. But really importantly, this is a prospective relationship. So it's not that the two problems are happening at the same time. We know that when there's insomnia, it's predictive of future depression, both within the pregnancy and postpartum. So that kind of implies a direction of causation. It's not just that the two things go hand in hand. There is something about sleep that generates mental health problems. And we were talking about postpartum psychosis. We know that sleep is likely to play a really important role, because we know that not needing to sleep or not being able to sleep is by far one of the earliest and commonest symptoms. And also in women with bipolar disorder who have an increased risk of postpartum psychosis, when they've done some studies following women up in the pregnancy and postpartum, women who lose at least one full night of sleep in the intrapartum period are 5 times more likely to get postpartum psychosis than women who don't. And so sleep is a very powerful thing. And on its own, it's independently associated with an increased suicide risk, even when you account for the mental health diagnosis and the severity of the mental health problem. So there's something about sleep that is so fundamental to our existence, to our ability to function, to our survival mechanisms. It's easy to dismiss it as part of motherhood, but it's a fundamental biological function.
Yeah. Exactly. I was just going to say exactly that. For some reason, it's very easy for us to just brush that off, but important not to because of all of the effects that it can have. And to try and figure out, I guess, how that can be treated and how you can ensure that you're getting a good amount of sleep, which I think leads us into, our tips for our audiences that are listening. So mothers, families that are supportive of mothers, healthcare practitioners, what are our suggestions for this period and for handling different conditions that may arise that are related to perinatal mental health?
I mean, I think the first tip, which applies to both patients and clinicians, is just recognize that these problems are common. And I'm not saying that to scare people, but I'm saying it almost to normalize it. So you need to have a high index of suspicion and to be able to recognize that there is likely to be a mental health problem if someone is coming trying to talk about one. But also as a patient, as a person, just be empowered to reach out, because actually struggling is more common than not struggling. But even in very serious conditions, so for example, I spoke about postpartum psychosis. In almost all women, they will return to their functional baseline and they will not have further episodes of severe mental illness. It's very treatable, and the outcomes are really, really good if you reach out in time, and if you're taken seriously. And so I suppose the first thing is speak out. Don't be afraid to speak out and look out for it if you're a clinician.
Absolutely. I think it's so important, and we talked about that at the beginning of the episode, and we've done a lot better with breaking the stigmas, but just because it's not sort of physical presenting, that doesn't mean that it's not a valid illness. And it's absolutely something to recognize, as the patient, we have a role in recognizing and reporting, and healthcare practitioners and anyone involved in that space has a role in sort of advocating for those people and ensuring that they get the right treatment. Absolutely.
Yeah, and I think it's important for women to know that you can and you will get better. So if you ask, it's not all doom and gloom. The outcomes are really good. You can and you will get better.
Yeah, absolutely. It's such an important concept to understand. This has been such an incredible episode and learning from you. So thank you so much for joining.
Thank you for having me.